Hello, good morning, everyone. We'll be starting our webinar shortly. I'm Joey Sescon, your host for today's seminar series from the Department of Economics and the Ateneo Center for Economic Research and Development. Again, I'm Joey Sescon from the Department of Economics of Ateneo de Manila University. Okay, so yes. Before we begin, let me just read some house rules. We will let the speaker finish her presentation first before we entertain questions. Zoom participants, kindly stay muted and stop sharing your video or refrain from sharing your video during the duration of the presentation. During question and answer, please virtually just raise your hand and wait to be acknowledged. You may unmute and show yourself when asking your question. Participants on Facebook, please post your questions in the comment section. Slides, videos, and other materials from the seminar series are posted on our website only when the speaker gives his or her consent for sharing them. Okay, so for today, we have a very interesting topic. Our speaker is Vanessa C. A health system and policy researcher for low and middle income country health systems. Her work focuses on health governance, health systems, strengthening, and development. She was on the team that conducted the first comprehensive review of the Philippines Responsible Parenthood and Reproductive Health Act, focusing on the national level governance. She also teaches for the Ateneo de Manila University Economics Department and Health Sciences program. She graduated from the Yale Graduate School of Arts and Sciences in 2022, just this year, with an MA International and Development Economics, and also worked as graduate student researcher in the Yale School of Public Health. Her undergraduate background is a double major in BS Health Sciences and AB Economics from the Ateneo University, where she graduated as class valedictorian in 2018. Si Van is a colleague and also my fellow researcher in some nutrition research that we've done for, I think, starting 2016. So I'm very proud to have Van with us now. Her topic for today is prosocial motivations for masking against COVID-19 in the United States, an empirical application for protection motivation theory for pandemic settings. So we have something very interesting for today, given the view of how the U.S. actually done uh, the as far as the public mask mandates compared to us here in the Philippines. So without further ado, uh, Van, kindly take the floor.
Hi, everyone. Thank you for that, Sir Joey. So I just want to make sure everyone can see the screen.
Yeah, can see it.
Okay. So hello, everyone, and good morning. I am Vanessa Sivan of the Ateneo Health Sciences and now also the Economics Department. And today I'd like to share one of the research projects I've been working on for the past year with Dr. Mark Schleisinger of the Yale School of Public Health. So before I begin, I'd like to preface that this is still a work in progress, as the coronavirus disease pandemic or COVID-19 is still an ongoing and evolving concern. We'd very much welcome the feedback, particularly on insights about the balance between self and other protecting motivations for engaging in behaviors that promote and protect public health. So with that, now I'd like to give everyone a brief background of the study. In other words, where I'm coming from and why I decided to pursue this topic. So I'm sure no one needs or even wants a reminder of this, but we have been in this pandemic since March of 2020. That is close to 3 years now. One thing I want to bring to your attention in this slide is how this pandemic felt as though, and sometimes still feels as though, it would last forever. But I want to remind everyone too that less than a year after the World Health Organization declared the novel coronavirus disease a pandemic, Many countries had already begun rolling out vaccines for the general public. Just a year after that, the US FDA had approved the use of antiviral treatments for a disease that originally had massive complications and few treatment options. Today, many countries are learning to live with COVID-19, including ours, the Philippines. Most people in the world have completed the initial two-dose protocol for COVID-19 immunization. COVID-19 booster shots are becoming a yearly public health intervention, and many places are lifting their masking policies. So, yet, it's not just these milestones that we remember from the pandemic. It now feels like a long time ago, but I remind everyone of the international headlines about toilet paper hoarding at the very start of the pandemic. There was a lot of panic buying around the globe because it was such a stressful and unpredictable situation. In particular, whenever internal movement restrictions or lockdowns were issued, such as community quarantines, short run panic caused people to be afraid and buy in excess, not just toilet paper, but also groceries and other consumer goods to regain some control of the situation. We were not insulated of this phenomenon in the Philippines. So if you remember, here are some photos from a Rappler News article that showed the extent of consumer panic right before the return to modified enhanced community quarantine. And this was all the way in August 2020. The issue was so prevalent that some local government units, such as Valenzuela City and Pasig City, implemented an anti-hoarding and anti-panic buying ordinance, which limited the number of consumer goods an individual could purchase for things like rice, eggs, oil, alcohol, soap, and toilet paper. Perhaps we were also exposed to headlines from other countries, like the US, about how service workers were treated or suffered from the aggression and belligerence of individuals who refused to mask, distance, or adhere to other public health precautions. You may have heard of the term anti-masker or anti-vaxxer circulate as a result. Yet, this is not the whole story. This was also a time of great cooperation. We had nations coming together to sequence the SARS-CoV-2 genome, develop vaccines, and share that knowledge so other countries could produce these essential interventions. We saw communities open local pantries and donate masks and protective equipment to healthcare workers. That's where the study comes in. We asked the question, what exactly did we learn about ourselves from this pandemic? Is the narrative of selfishness what dominates, or one of empathy and consideration for others? After all, this is by no means the end of COVID. The US has reached 1 million deaths due to COVID this year, the highest number of any country in the world, and the highest number of confirmed COVID deaths for any high-income country in the world. The Philippines has surpassed 64,000 COVID confirmed deaths, the highest in the Western Pacific region. We still face the challenges of long COVID, which is poorly understood. This also won't be the last pandemic. As new variants of COVID arise, they will limit the effectiveness of our existing strategies to reduce spread and treat cases. And changes in the global ecosystem will also increase the probability of zoonotic diseases, which, much like the disease etiology of the SARS-CoV-2 virus, is caused by this new interaction between humans and animals. How then should we think about not only masking, but in general, how people protect themselves and others during a pandemic? I take you now to the framework of the study. In particular, we adapted the protection motivation theory framework for pandemic settings. The PMT framework has four main components: perceived severity, or how dangerous the threat is; perceived vulnerability, which is how likely I am to be affected; response efficacy, in other words, how effective is the coping strategy; and self-efficacy, which is how capable am I of engaging in the protective behavior. What you observe from the framework is that the traditional models of risk tend to look at individual or personal-oriented risk, how the threat harms the individual, and how the response can protect the individual. This framework has been applied many times in health, and there are even applications related to the COVID-19 pandemic. The rationale behind the framework is quite intuitive, and you can see it at work in our current COVID-19 guidelines. For instance, earlier this year, the Centers for Disease Control, or the CDC, recommended that individuals base COVID-19 prevention on objective measures of risk, such as hospital and bed occupancy, local or community transmission rates, and pre-existing health conditions that pre-expose severe COVID-19 infection. Here in the Philippines, with the lifting of masking mandates both outdoors and indoors at the national government level, individuals were advised to mask based on their personal risk levels, such as being elderly or immunocompromised. So the question I asked was whether first, the PMT would be available to this particular setting of the COVID-19 pandemic. As I'll describe later, the study took place more than 2 years into the pandemic when vaccines were widely available, states were easing on masking restrictions, and pandemic fatigue had set in for many in the US. This was just to validate the framework for use in the study. One unique feature of the pandemic, though, is that taking protective action for the self, in this case, masking indoors, also serves to protect others. The pandemic has been a global, prolonged concern, and that has made it a relevant setting for the study. Viewed in this light, we can seek to understand not only whether masking indoors is motivated by personal-oriented risk, but also social-oriented risk. In other words, are people willing to mask because of concern for other people? This is not completely new, and it's not an entirely unfounded concept. Pro-social precautions against COVID-19 have largely been portrayed as the need to protect vulnerable groups who are at risk for severe disease or death due to COVID-19. These include older adults and people with medical conditions such as cancer, chronic kidney disease, chronic liver disease, chronic lung disease, heart conditions, pregnancy, and people who are immunocompromised. The messaging during community quarantine or even NECQ was that we should stay home to help our essential service workers or healthcare workers, and this also reflects this sort of thinking. So in the second research question, we took a look at whether individuals' masking behavior is motivated by social-oriented rational factors. And I say rational here very deliberately. If you take a look at those factors I listed, they were very objective, very numerical, very black and white. Hence, I'm going to describe them as rational factors. But another important dimension of risk assessment is the interplay of cognition and emotions. So research from previous pandemics, such as the 2002 SARS outbreak and the 2009 influenza A H1N1 outbreak, found that knowledge of the pandemic alone was not enough to motivate precautions. Health psychology theory posits that individuals make risk judgments according to fast and frugal heuristics. Situations of both uncertainty and risk, like a pandemic, prompt an adaptive response based on limited available experience, information, and intuition that may not necessarily be viewed as rational. So the final thing we looked at was whether emotional factors, both the personal and social oriented, might be a cause for masking. With these three questions, I'll briefly go over the data sources and the analyses that were done before taking you to the results. So the data came from a representative survey of US residents conducted by Yale University and Ohio State University for the period October to November 2021. The following information were collected for over 2,500 respondents, but when considering respondents who had answered all of the pertinent questions for the analysis, there were 2,153 responses. These respondents also represented all 50 states and the District of Columbia, which the US Census Bureau also considers the statistical equivalent of a state. And they represented 961 or 30% of the 3,195 statistical equivalents of counties in the 51 states. Survey items corresponded to 3 different domains of the PMT framework, and they were used in the analysis. So broadly, the questions fell under the category of COVID-related questions, with the respondents' masking behavior as the main outcome of interest. And then rational motivations included respondents' propensity for severe COVID-19 illness, the respondents' personal and their social networks experiences with COVID-19, their beliefs about the effectiveness of masks, and their household vaccination status. The emotional or affective motivations included the respondents' worries about the pandemic's impact on their health, worrying about infecting others with COVID-19, and their empathy for others, particularly essential workers during the pandemic. The second group of questions were social demographic characteristics such as age, sex, income, education, country, and state of residence, and also political affiliation. So these were included as they were shown to be associated with masking and other pandemic precautions. To supplement analyses, a third set of data were needed. Additional county and state level data were collected from public databases and matched with each respondent. These included the state COVID-19 incidence and mortality rates, which were obtained from the Centers for Disease Control and Prevention, and state COVID-19 policies obtained from the Kaiser Family Foundation and COVID-19 US state policies databases. Data were also collected on which party was in control of each state, and these were matched with each respondent's county and state respectively. So I'd be happy to share more about the survey with those interested, but in the interest of time, I will just note that the interpretation of each survey item was corroborated with the researchers who developed the survey tool, and that the survey had been pre-tested and deployed several times over multiple years before the current data were obtained for the study. So the study adapted its econometric model from two papers, those of Ateneo et al. And Kahane, both of which were published in 2021. The former gauged pandemic risk perceptions with individual and emotional rational threat appraisals. However, the study was set in France. So to better contextualize the model for the US, additional variables were adapted from Kahane, who investigated the determinants of mask wearing in the US at the county level. But before I get into the results proper, I want to give you an idea of who the 2,119 respondents were for this study. So the respondents were balanced in terms of gender and political party affiliation. Respondents' education level and household income resembled somewhat a normal distribution. While mid-ranged ages were representative of the US population, the youngest group were slightly underrepresented by a few percentage points, and elderly respondents were also slightly more represented than in the US. So it's 38% compared to a little over 32%, which may be attributed to the telesurvey mode of administration. Previous studies have found that elderly respondents were more willing to participate in personal interviews over younger ones. White respondents were also more represented than they are in the general population. In the US Census, 60% identify as white non-Hispanic, while here it was 75%. And again, it might have been due to the telesurvey mode of administration. So 2,119 is not the biggest sample size, but there is still value in the data because large-scale quantitative surveys that capture the individual level lived experience of the pandemic are rare. And the representative national scale survey proved valuable to present a nuanced view of respondents' masking and COVID-19 perceptions. And then before we get to the regression results, I also want to elaborate a little on what was meant by masking. So the specific definition of masking here is masking indoors while in public spaces. Because in the US, masking outdoors was not really a major recommendation by public health officials. Survey respondents were asked, how often do you engage in wearing a mask when in a store to capture their masking behavior when they expected to be unable to social distance in an enclosed space? Answers were never, rarely, sometimes, often, and always, and they were assigned values from 0 to 4. As you can see in this table, even though only 9 of the 51 states had a mask mandate at the time of data collection, states with mask mandates still had a greater share of always maskers, which is around 67%, compared to those without mask mandates. And also, while states without mask mandates had a greater share of never maskers than did their counterparts with mask mandates. However, the data also show that mask mandates do not completely explain masking behavior, as other reasons motivate more than 70% of respondents in states without mandates to mask at least sometimes. So this was consistent with other studies that found mask mandates increased the likelihood of masking. Thus, aside from controlling for the social demographic characteristics, state policies about masking also needed to be controlled for. The other thing I want to note is that the responses to the masking questions are ordinal. meaning that the order never, rarely, sometimes, often, always matters more than the interval space between 0 and 1 or 2 and 3. Because the responses were ordinal, the analyses used ordered logistic regression. I bring this up because the results are presented as odds ratios to aid in the interpretation of the regressions, not just standard numeric coefficients that you'd see in most economics papers. So this is standard practice in much of health research, but I wanted to state this early. So for example, if the odds ratio is 2, that means that a 1 unit increase on the motivation or regressor increases the likelihood by 2 times for the top 4 categories, which can be interpreted as any form of masking compared to the lowest category, which is never masking. So now let's get to that first research question. Is protection motivation theory applicable to the current study setting? The first regression just assessed the mechanisms of the standard PMT framework, the personal-oriented rational factors, which are severity, vulnerability, and response efficacy. As masks were widely available and accessible, including very cheap or distributed in indoor public spaces for free at the time of data collection, self-efficacy was assumed to be the same for everyone. Then the social demographic and policy factors were controlled for in the regression as well. So for the domain of perceived severity, the variables were whether the person had a chronic illness, which will increase their chance for severe COVID infection, and the number of COVID-19 deaths at the county level. We see that any additional COVID death doesn't really increase the odds of any form of masking compared to never masking because the odds ratio is 1.00001. Which makes sense because seeing 1,000 versus 1,001 deaths doesn't have a huge impact in our perception of the problem. However, when looking at perceived vulnerability, which is one's personal vulnerability to COVID-19 exposure, this has an odds ratio of 1.1. So with going from, say, not worrying to slightly worrying about the health consequences of COVID-19, the odds of masking are 1.57 times higher, holding all other factors constant. As for response efficacy, or the belief that masks can protect oneself from COVID infection, the odds ratio is 2.28. This means with a movement from neither agreeing nor disagreeing masks are effective to agreeing masks are effective at protecting the self, the odds of the combined 4 categories of any masking as opposed to never masking are 2.28 higher. Now, how do we interpret these findings? The framework does make sense for the setting. If you think about it, a disease can be very severe, but if you're pretty sure you're not going to contract COVID in the first place, then you won't be that interested in protecting yourself. Similarly, the threat of COVID might seem very pressing and dangerous, but if you don't think masks will protect you, then you'd try to mitigate the threat in other ways, not masking. And this is about true for the COVID-19 disease. Most people didn't perceive it as severe, especially at this time in the study. In fact, the prevailing health beliefs at the time, when vaccines were again widely available because this was the fall of 2021, were something like COVID as a bad cold or a bad flu for most people. So now we can move forward with the main question of the study. Is masking motivated by social-oriented factors? So in this model, we not only control for all the social demographic and policy factors, but also the individual-oriented or personal-oriented factors as well. And what we find is that the additional vulnerability of one's social network to COVID-19 exposure leads to the odds of masking being 1.1 times greater than never masking, again, controlling for personal-oriented motivations. Believing masks protect others doubles the odds of any masking compared to never masking. I reiterate that, again, this is while controlling for personal-oriented factors already. From this, we can say that people don't just mask to protect themselves, they mask to protect others from the risk of COVID-19 too. And there are several explanations for this. On the one hand, if your social network is very likely to get COVID, even if you yourself aren't, your likelihood of getting sick also goes up because they are the people you interact with. Similarly, if you believe masks protect others, then even if you don't really believe masks can stop you from getting COVID, you'd put on a mask because you're not sure of your own health status and that protects other people from being infected by you. I also want to highlight that the inclusion of social oriented factors diminished from the personal vulnerability to being exposed to COVID as a significant motivator for masking. In other words, the odds ratio for those factors went down. And that also makes sense because, especially in the beginning of the pandemic, the science at the time said that masking works best when we all mask. And the message we received was that masking is far less effective when you're only masking to protect yourself, um, rather than when you're trying to protect others, because the masks primarily keep our own respiratory droplets from spreading. Today, we know that well fitting, highly protective masks can keep us safe from COVID together with other preventive measures, though masking is still an effective means to reduce COVID transmission. In the third regression, I included the emotional or affective components. So, worrying about passing COVID on to others increased the likelihood of masking compared to never masking at all by 1.2 times. And for empathy for essential workers, with a shift from perceiving essential workers being slightly more at risk to moderately more at risk for COVID-19 compared to the general population, the odds of masking are almost 1.5 times compared to never masking. The likelihood was greater than for a similar unit increase in worrying about the consequences of COVID on the self, which has an odds ratio of 1.29, holding all other factors constant. You'll also notice that social network vulnerability to COVID-19 exposure was no longer a significant predictor of masking under this model. So how do we interpret this again? To answer that final research question, emotional factors, both self and other-oriented, were indeed shown to motivate masking. Given the lengthy duration of this pandemic, and as a result, many individuals or their social networks already had experiences with COVID-19, and the availability of other preventive measures such as vaccination, you can see how rational factors like exposure and severity may have played a less role in their decision to mask. On the other hand, emotional factors by nature defy logic. So for these situations, it matters less whether data show the danger of something to myself or others is low, if I feel very strongly that it isn't. Here's the summary of the main regression results, just comparing the changes as the model is augmented, first with social rational motivators in the model 2, and then with social, rational, and emotional motivators in model 4. We still have time, so I'll also share what we found about how policies affect masking behavior. So here you'll see the models 1, 2, 3 again, but earlier, all I showed was that we controlled for different policies, right? So here are the odds ratios for each of those policies. You saw that I talked about state masking policies. So state with mask mandates increased likelihood of masking more than threefold over those without mask mandates. And this was after controlling for respondents' political affiliation, as well as whether states implemented an override of local mask mandates. So Republican respondents were also less likely to mask compared to non-Republicans. The augmented social model, which is model 3, shows the odds of any masking over never masking are about half when a respondent was Republican. Similarly, the odds of masking compared to never masking in Republican-controlled states was 0.8 compared to non-Republican controlled states. However, either pro-social rational motives such as masks for others or pro-social emotional motives such as empathy still remain significant predictors of masking, as you saw in the previous tables, even when controlling for these, as we saw in those slides. An interesting finding was the estimation of state ban of local mask mandates, which were enacted in 6 states, all of which were Republican controlled. So for those states, they not only didn't have a mask mandate, they also banned any local government within the state from enacting some kind of mask policy. And we found that the likelihood of masking over never masking was 1.5 when states overrode local mask mandates, even when controlling for local COVID deaths, political affiliation, and state party control. So this just on the surface would imply that increased masking in states with mask mandate bans is not only a function of the greater number of cases or deaths in those areas or that more people in the state vote Republican. And this is odd, right? You'd expect a ban of masking mandates to lead to more people perceiving masking as unnecessary or even problematic. A potential mechanism may come from some other state factors, so not shown here, but we also compared the models with and without state dummies. And the inclusion of state dummies clarified that banning mask mandates more than halves the odds of masking with an odds ratio of 0.43. However, it's only significant at the 90% confidence interval, and the lower bound odds indicate that at worst, mask bans reduce the likelihood of masking to just 0.17, which is about one-sixth compared to states without mask bans, and at best only increase the odds of masking by 0.30. The reason I didn't present it was that state dummies were reintroducing the multicollinearity issue because of the smallish sample size. So 3 of the 51 states were omitted for multicollinearity. And moreover, state dummies captured other state characteristics we already controlled for, like the political party in control, which was already included in the regression. So these findings suggest the need to investigate a more precise state mechanism relating to mask bans that contribute to masking without reintroducing all 51 state dummies, hence why state dummies were not included in the main models. I thought I'd also show the odds ratios for the different social demographic factors for those interested. So the findings from the social demographic factors were quite consistent with literature. Younger people were less likely to mask than were older people. Higher income would have a slight decrease in the odds of masking. Education predicted higher odds of masking, and Black, Hispanic, and Asian groups were all more likely to mask than were white Americans. But I would say these social demographic groups are not what people can easily change about themselves, though there is room maybe for more tailored messaging to them. Instead, I want to focus on the so what of the main study results. So what did we learn and how can we use what we learned? The first thing is the narrative we tell ourselves about the pandemic. A lot of us remember the pandemic as a time of selfishness and inconsideration, especially over something as simple as masking. But individuals do care about others, and they're even willing to put on a mask. So this is considering the context of the study too. The US is a country where individualism is in high regard. In the US, masking was also highly politicized, meaning one's political party endorsed ideas about masking as an impediment to one's personal freedom. However, the results show that even after controlling for individual-oriented factors, political motivations, and state mask policies, believing masks protected others predicted masking in the US context. The odds of any kind of masking compared to not masking at all were twofold, from shifting one's opinion on the effectiveness of masks from neutral to agreeing that they were. Future public health interventions may also integrate other-oriented messaging in their health communication efforts, especially as many public health issues impact populations and not just individuals. While it is still important to talk about the impacts of health problems to the self, appealing to our concern for others may increase adherence to, compliance with, or participation in a public health policy. If it worked in the US, what more in countries where collectivism is more a hallmark of society, like many countries in Asia? The second thing is that among the rational motives included in the models, a belief in the effectiveness of masks as a preventive measure dominated over cognitive knowledge over one's exposure to infection, even when emotional, policy, and social demographic factors were all accounted for. These findings suggest that individuals do not make masking decisions based on purely rational risk and cost assessments. Instead, their perception of the response may shape undertaking protective behaviors. Community education about the effectiveness of protective or preventive responses is a potential application of this finding. Because public health issues are often presented in terms of harms, adherence to a protective behavior is in turn presented as a way to avoid harm. However, advocating for the benefits of the intervention or behavior may also be a way to mobilize communities to partake in health promoting behaviors. Whether it is getting patients to have regular checkups, take their maintenance medication, engage in physical activity, or avail of an annual immunization, only impressing upon them the risks and harms may negatively frame the entire process in their minds, and maybe a positive framing can change that behavior. Third, the findings suggest that individuals do not make masking decisions or any other public health prevention based on purely rational risk protection assessments alone. Instead, more gut feel factors such as worries or empathy also play a part in the decision making. The small effect of county level deaths supports this notion, right? That a practical significance in the likelihood for masking can be observed only when local deaths from COVID-19 increased by the thousands, which would raise the odds from 1.0001 to 1.1, imply respondents' understanding of disease severity may be drawn from an impression of the large numbers or a sense that the disease environment has shifted. This suggests that during an uncertain and protracted pandemic, protective decisions are made using fast and frugal heuristics over a systematic cost benefit analysis. An alternative channel for intervention is then through an appeal to empathy and other emotional motivators of masking. Empathy was practically shown to increase adherence to physical distancing in other studies of Western countries as well. Two experimental studies presenting information on the importance and effectiveness of physical distancing or masking alone, compared to that information with an empathy portion, found that inducing empathy could promote adherence to distancing and masking. So the empathy component in the study was a brief testimonial of an elderly man who could not visit his hospitalized wife because of COVID-19. On the other hand, those in information only groups were not more motivated to distance or mask. As the past decade has shown, the information media landscape has tended to favor anecdotes and testimonials, the use of rhetoric and personal storytelling. While powerful, these have also fueled things like anti-vaccine sentiment, as well as distrust in our scientific and political institutions. Introducing affective components to health interventions traditionally involved appealing to human experiences of fear. However, repeated exposure to fear-based messages, such as in a long-term pandemic setting, can diminish its impact or instill a sense of indifference and pandemic fatigue. Promoting habitual, responsive health behaviors may be more likened to promoting moderate drinking, which relies on individuals planning their drinking behaviors based on deliberation over personal circumstances. Positive messages can evoke personal control over the situation, even when there are social pressures to do otherwise. Consequently, one-on-one communication through primary care providers and smaller-scale mandates from local community leaders should also be explored over broad national or state messaging. Increasing empathy in primary care providers through communication skills training or reflexive role-playing has been found to increase patient satisfaction and may improve adherence to preventive recommendations. Finally, the results showed that mask mandates predicted any masking at triple the odds of never masking, even controlling for respondents' own political affiliation and state political party. At the time of data collection in fall of 2021, statewide mask mandates were being rolled back, with only 9 states with mask mandates compared to 35 at the start of the year. Implementation has also been uneven throughout the pandemic. In March 2021, though 35 states had mask mandates, 17 did not have any legal enforceability. Over 2 years of the pandemic, the implementation of mask mandates was left to businesses, community norms, and other private actors. However, the results suggest that the presence of mask mandates or formal policies alone may be sufficient to clearly signal the urgency or severity of a particular health problem, and thus should be used sparingly. I present here a summary of our key findings and policy implications. By considering these applications of the research, I hope we can think about public health interventions a little bit differently, remembering that people don't live and behave as if they're isolated from one another. So this concludes my presentation. Thank you very much, and I look forward to your questions.
Thank you very much, Ban. It's something, actually, it's something good to discuss, given that we have like more than 2 years now of the pandemic, and we have kind of observed how we go through it and how governments around the world also went onto it. And the interesting one is that I maybe give some frames on what's interesting to us with your study. There is the side to ask, probably some students will ask about the methodology, like what's the difference with an odds ratio and measuring probability. If you use probability, use in the econometric side, probably for those who are more on political science or social, probably the the thing that I impressed with, I was asking like, okay, I know that some people are motivated emotionally or something like that for more altruistic behavior. But what I'm interested actually is how many of people are really care about others and not. But you presented a slide if you are a Republican, if you do this, so you actually also covered that one. Those are probable questions also in your study. You have a U.S. situation where mass mandates are politicized, and in the Philippines, it's not really that much politicized. But there's not much very systematic study on wearing masks that I'm not aware. But yeah, so please ask questions, and if there's no question yet, please you can raise your virtual hand and I call you up. Can call you up. Before that, I can. Okay, okay. So there's no question yet. So I think I'll probably ask the question ban just to uh make the roll the discussion up. So yeah, with regards to the motivation, no, you said that it's a really a combination, right? It's not plainly what's the benefits, what's the harm. Actually, when there's a pandemic, the disease, or actually, well, this is the harm that will get into you. And the trigger here in the Philippines is actually when you can see images of hospitals, bursting with patients, no? And I think much in the developing countries, the trigger of lockdowns is really the hospitalization rates. That's the one. The US, they can actually expand their hospitalization accommodation, and here that's the trigger, the harm that you will get into. uh and the benefits actually also that you will protect others, that's one coming. But the thing that your study is also saying is that people have emotions, people have their own ways of responding. That's why it's a really complicated when it comes to health. It's really a complicated one with regards to the objective ways, that objective information of what is a COVID, what harm will you get, and then therefore what benefits you will spread out if you wear a mask. At the same time, you have uh, disinformation, and the same time you have political beliefs. The same time you have different persons on how they perceive dangers. You have different persons, they will take different risk. Some persons would say, uh, bring it on. Some people would say. So my question is really with regards to that, your findings, do you, as a researcher and into health economics, did you find anything with your study that is different really from what is mostly perceived with regards to health behavior? I think you have done a lot of the literature review with regards to health behavior. Is there a difference in how people are behaving with regards to other than the politics in the US?
That's a really great question because in scoping the literature for coming up with this model, a lot of US literature and even international literature kind of painted the US situation as already one where it was very individualistic, where people were kind of looking out for themselves, and the main goal was really a value of personal freedom rather than a collective responsibility. So, for instance, there would be studies about what would predetermine having social oriented motivations, and there would be comparisons with like collectivist countries like China, and then very individualistic countries like the US, and it would kind of generalize those results and say, see, so in countries like the US, you're not likely to help other people as much as you were if you had this sense of collective responsibility. Similar for a lot of Western and Central European countries, which people felt also had a lot more collectivist or social responsibility for health. And that's why at first I also felt like the original model, which was set in France, wasn't going to be sufficient to kind of answer this question. But the other side of the coin is that a lot of literature about understanding why people mask really focuses on their social demographic attributes, like their age or their race or their political orientation. And of course, all of those studies would say if you're in a Republican state, right, you're not going to mask much. Or if you are in a place where there are no mask mandates, you're less likely to mask. And what I wanted to say was, if you take all of those things into consideration, um, could you still figure out if people would mask for other people? And the answer is yes. So I was pleasantly surprised by that result, but I also, it gives me a lot of hope for the way we present our the public health interventions,
That's
because
the thing interesting, right? A lot, the world over has a very negative impression on American behavior with regards to this. Like there millions died in the US, no? And people are wondering why are they not reacting to the number of deaths so that they will actually be masking because of that, no? But your actually your results, even if this is a small study, small study, but it's a representation of the whole US. It's only a few thousands, but as a representative sample, it's a small study among all studies, but it actually gives you a point of view that it's just about mask, wearing mask, but it has implication with how to read the American public, in the sense that even if you have a negative impression that Americans are individualists, they don't really take care of each other and so on, because what you can see with regards to the COVID situation, they don't just care, and there's so much politics to mass mandate. But your study is saying that there are people who are still, are motivated, do something what benefits others, and do something. But of course, there are tendencies as far as their beliefs and affiliations, even politically. So I think that's one message. Sorry, my cat is pushing my screen. Our cat. So yeah, and there's a question here. So what could be the implication for the Philippines given the individualistic uh, nature of such Western models versus the family community oriented Asians or ASEAN in particular? Steve, you might want to ask this personally, or okay? Uh, Steve?
Hi,
Yeah,
Van. Nice to see you.
yeah. So this is Steve. I
Yeah.
know you, Steve. Yeah. Okay,
Hi
yeah,
there.
you may want to
we've
ask
also
it.
met on online.
Uh,
Online. Yes. Yeah, my question, thank you for reading my question, sir. I'd like to reiterate again, what could be the implications, given that the models that you've said is rather individualistic and focuses on oneself, or rather than implications to versus the Philippines or ASEAN in particular, being collective or family oriented.
I really appreciate that question because when I was preparing this presentation, like the first thing I was thinking about was how to make it applicable to the Philippine setting. And for me, it's because at this stage in the pandemic, we have also reached a point in the country where we're less relying on national direction to exercise these decisions about which precautions to take. And in the latest memos that were released or executive orders, we're also told to mask based on your own discretion, really. Like that's what the tantamount message comes to. And if that's the case, then it is also understanding that we cannot continue to get people to protect themselves only by instilling fear or by pushing the negative effects of a pandemic, because very understandably, people are also tired and people have also been very strong for the last almost 3 years. So it's understanding that if social oriented factors can be a motivator, even in an individualistic setting, what more in a setting where we already feel some collective responsibility to protect one another? And maybe that is where the messaging can focus.
So
Thank
yeah,
you very much.
thank you, Steve. So well, we can proceed to discuss one. So I have a lot of questions in my mind, but you know, the other one, let's bring it to the extreme. We have China that until now are doing lockdowns and the state mandated, and they do testing a lot of times. And with regards to your findings, that the harm that you will get, the first messaging may actually uh, reach out to even making to for people to do responses. But as you put more messaging that this will get into you, you will be harmed, etc. There is what your study is saying. There's a point there that it may not be effective anymore because there is then there this the study of your study saying that people actually weigh the benefits and costs. And actually, what if you read China now, the people are reacting according to the benefits and cost of the lockdown. Um, this is the fear of the messaging that we have to lock down because if we don't have lockdown, this is Omicron, this will spread very fast and so on. But the lockdown costs are the ones now affecting China citizens of China, and they are protesting as well. Well, in different ways of protesting because that's it. No, the messaging of the Chinese government is saying we should lock down, but people are actually complaining now in their Weibo chats, etc., because they actually what I can read is that what I can say is that the cost for them are actually probably higher than they think about the benefits of the lockdown until now. And all other countries are not into lockdown except China. So I know it's comment rather than a question, but it still refers to your study about messaging.
I would say also that the policy goal is different. So for their situation, it's really zero COVID. And that's why they're focusing on lockdowns and testing rather than masking and immunization, which will reduce transmission and reduce severity of infections, but not really completely stamped it out. And that's why the policy there has been much more aggressive. And I think,
Mm.
like you said, it's a very distinct case because even the goal of the policy is different.
Mhm. Yeah, the zero COVID. So Doc Nina has a question here. I may have missed this in your study, but does education and or income level matter in decisions to wear masks out of concern for others, concern for oneself? I know that you have this in your regression results, but please elaborate.
So thank you, Doc Nina. It is in the results as well, and it's very similar to all of the other literature. So having a higher education will increase the odds of your masking. And in this case, actually having a higher income level just slightly decrease the odds by like 0.1 likelihood of masking. And I didn't really talk about it at length because I didn't feel like it was anything particularly new or that people hadn't heard of, but it aligns with the literature that the more educated people are, the more they kind of understand the risks of infection, or at the same time, they might understand why we need to mask for other people. And for income, in the US, it's a bit different because very high incomes also mean that you're able to work remotely, that you don't need to take public transport, and that might have explained why the odds of masking were slightly lower for those with very high income levels.
So there you go. So is there other questions? Um, with regards to your study again in the US, the pandemic seems this is more on the political side, social side. The pandemic seems to have, you have a very politicized, polarized situation. And then the pandemic came, the election happened right there in the midst of the pandemic. I think it was 2020 December or 2021 December. I 21,
2020.
yeah, yeah. And so the pandemic and even the mass mandate became a political something. So uh, it exacerbates, pandemic or whatever it is that comes. If there is something that is playing politically, then it actually just exacerbates, or yeah, probably because if disaster comes, actually nations and communities can get together, no, and unite because there's a disaster coming. But the readings in the US, but at least your study is actually saying something also about pro-social motivations rather than the readings. It seems that the impression, of course, that the pandemic, instead of being, let's unite because there is disaster, a disaster is happening. But what is popular reading in the US is that they actually get more politically polarized because of the disaster. But you can comment on that. Even with a study of yours that is not really a political one, but there's some politics there.
That's a really good point, though, sir. And one of the things that I did put down as an implication when I was writing this, but not for this presentation because I was afraid it wouldn't be very applicable, was how we might depoliticize not just masking, but other health interventions in general, because the data that I was able to get were at the state level. And even the state level is very politicized. But if on the one hand you can push health messaging or health communication through primary care, which is at the most local basic level of the health system, what if you can also do that through local governments? Or what if you can also do that through local organizations? Then that can more easily depoliticize the issue rather than if it were coming from like a state representative who needs to also carry the weight of the party, be it whatever party they're from. So that's one potential opportunity for future studies, really, to really gather data at the more granular level for local governments as well, and see how that messaging might have impacted people's masking.
Yeah, yeah. That's really good. As far as the Philippines, the LGU matters. The local government units matters. Its relationship. How you have the national messaging, the DOH doing public press con every day, and March 2020. But eventually, the people will look at the local government units. Uh, how the LG will respond, and also react on those responses. So there is a lot of influence as far as LG. We are 10:58, and I think we don't have additional questions. And I think before ending, of course, uh, thank you very much, Van. I think because of there's I think I don't want feel guilty here, because even if I done a lot of questioning rather than the audience, well, you should have given questions more. But anyway, thank you very much. Thank you very much for those. Before I end, three times we have some reminders. Yeah, the next webinar of the department as well as the third is by our faculty from the department. Again, this is a faculty series webinar. May read from Dr. Mir Magante, an in-depth analysis of teachers' financial literacy, path towards improved financial education for Filipinos. That will be December 7, and I think this is the last for this semester. So with that, yeah, our visit our website for the materials from previous seminars. Also the videos are posted in our Facebook page also. Okay.